So as we were featured, we were in
Got
color,
color.
and they would put. I'm Barbara Owens. My mother and daddy was Herschel and Ruby Burtz. I graduated here. I was born here in Union County. Graduated from at that point was W.P. Daniel, which is New Albany High School now. Went to Northeast. I had the opportunity to begin working at Union County General Hospital when I was 16 as a ward secretary on weekends. Mother was there as a nurse, and they needed a ward secretary on weekends, and the director of nurses asked Mother, did I want to work? And she said, sure. They had 4 children. And so I started working at the hospital. It worked out that when I graduated from Northeast, they had an opening in what was in medical records at the hospital. And so I took that job. I've been blessed over and over. I was in the job about 3 weeks when the director decided she would move to Memphis. So our administrator at that time, Mr. R.H. Harrington, he asked me if I would be interested in that role. And I had just become engaged at that time, and I said sure, and not having a clue what it was going to entail. But I took the job. The hospital offered to pay for me to become accredited. You had to be accredited to have that position. Here goes my hands. And so I took a 2-year course and became accredited in medical records management through the hospital. That was my start.
I'm Sam Creekmore. I was born in Amory, Mississippi, and went to Mississippi State undergraduate, then Ole Miss Medical School at University of Mississippi Medical Center, and then Savannah Memorial for my internship. My mother, when I was in high school, senior, didn't have any clue before I went to state what I was going to do, so she said, "Be a doctor. And I said, okay, about as well." So that's how I got into medicine. And my daddy told me, he said, if you don't make it, you can always come back and sell tractors with me. So I kept working pretty hard. In Savannah, we went with Dr. Russell and Dr. Randy Randall. We were all in class together at Ole Miss, and we went to Savannah together as an intern. While we were looking for a place to come practice, Randy said, New Albany, where I'm from, he was born here, is looking for doctors. Said, I'm not going to go back. I'm going to go to Georgia. Said, y'all ought to go see him. So we set up a time. Mr. Deaton and Bill Smallwood, who was on the hospital board at that time, kind of helped arrange it. They brought us in and showed us the hospital, introduced us to the doctors, which was Dr. Speck, Dr. Ellis, Dr. Boswick, Dr. Bramlett. We had Dr. Philpott was a pathologist. Who was our radiologist then?
I don't remember.
A part-time radiologist. And they were all very kind. Dr. Boswick and Dr. Ellis, Dr. Thornton all said, this is a great place to practice. Don't worry about having patients. Do your job, be available. Practice medicine, you'll always be busy. The hospital board was super nice. The board of supervisors met with us. We had a big lunch at the country club, and the bankers were there, the preachers were there, and a lot of young people. New Albany had a lot of young people coming back, our age. And so we left out of there. We'd gone to Corinth and Boonville. The doctors in those 2 places wouldn't even talk to us. They were too busy and didn't want us to come. So we said, let's go to New Albany. And we signed the contract that day. The hospital board, the board of supervisors agreed to build us a building for us to rent. And we came back in July of 1972 and started practice. Been a great opportunity. We got here, the hospital had just been built about 2-3 years.
1966.
Okay, about
10 years.
Time went by fast. But it was a relatively new hospital, Hillburton. Hillburton gave money to build these hospitals with the stipulation that you couldn't turn anybody away.
Yes.
Which was very important because the private hospitals that were around wouldn't see the patients who couldn't pay, so they would be shipped to our emergency room, which is good for the practice of medicine, bad for the finances, but it worked out. I think it was to our benefit, really, and to the benefit of the community for sure. We were fortunate because we had Dr. Bramlett, who was a great surgeon. He was recruited by Dr. Shands, who was the surgeon before him. Dr. Shands was about 56 and he had developed colon cancer. And he recruited Dr. Bramlett from Memphis to come and take his place. And how he got him, because Dr. Bramlett was well respected in Memphis, had a great practice. He'd done a year in Sloan Kettering in New York, cancer surgery. So he was super qualified, a great man, and he worked hard, like Dr. Shands apparently by history had done. And so we've had a good heritage. Dr. Pennebaker had died about a year before we came. Dr. Pennebaker, the stories we heard about him was on his days off, he would go around and throw candy or gum out to the kids that were playing outside, hard active father. Dr. Robertson was in family practice, and he had died a few months before we came. And people loved him. He apparently was a great guy. Dr. Mays, we heard about stories, but we didn't never know anybody. We didn't know him, didn't follow his practice too much. Dr. Shands was a legend. When we got here, the people were very receptive. Our practice built up very quickly, and we began to attract people to come and practice in New Albany, which was kind of what we needed. Dr. Shirley was our first patient person. He was from Saltillo. And so we found that people who lived in this northeast Mississippi region were the good ones to come. If they didn't live here, they were harder to stay. But if they lived here, they came back. And we grew from there. We recruited several more. Dr. Harding came. Dr. Chisholm in OB came, and he brought in Dr. Williams about a year. So that made the OB practice really grow. Then we got Dr. Googe, pediatrician. He was from Boonville originally. Dr. Chisholm was from Fulton. And Dr. Googe added to the nursery. The nursery built up and became, and we began to grow from there. It was just a continued growth. Got a radiology, full-time radiologist. I've got a full-time pathologist, and all these things we needed to grow at that time. So that was the kind of the golden years, I guess, of our medicine. We could practice like we wanted to. The records nobody was looking at except Barbara. And then we began to get, the cost of medicine began to grow. We got CAT scans, we got new operating equipment, and so the price of care was expensive. And people coming in that we couldn't turn away, and Medicare was always in the red, Medicaid was having trouble. So we began to have rules and regulations on what we could do, how long people should stay in the hospital, how you should treat certain illnesses, to begin to standardize the care of medicine, which was good because it made sure that everybody was getting proper care it was supposed to. It was bad because it took away everybody's unique properties. Some people had unique needs and they would require more than others. And that's where the DRGs and Barbara would come in. Now you can tell more about how that would affect.
Well, the hospital has served our community well. We had a huge OB practice. Before we had our OB physicians, we served about a 5-county area of deliveries. People came from everywhere.
There was no other people delivering.
No other people delivering. So our census was really, really good. Our doctors could come in, they could see their patients, and they could go to their offices, which is was what they wanted to do. DRG changed that in many ways. We began to work together to standardize protocols. An example of that is Dr. Creekmore might treat congestive heart failure one way, Dr. Russell treated it another way, Dr. Ellis might treat it another way. And the cost at that time was okay, but when DRG came into effect, and it was around 1973, then we had to look at that because we only got reimbursed a certain amount for congestive heart failure. That's a good example. If there were comorbidities and complications, the physicians had to document. This is where we had many discussions. That documentation validated what was wrong with that patient because Medicare checked. They developed several organizations. One of them was the International Quality of Healthcare out of Jackson. They would come routinely to check that what you were billing was documented in the medical records. So our doctors worked really, really hard with us. We worked many long hours looking at the care for pneumonia, looking at the care for CHF, looking at surgery. The surgery was the same way. You had to use the same suture. No longer could the three surgeons use a different suture because that was their favorite. They had to standardize. So there really wasn't anybody in the hospital. No physician was left untouched in that time.
And we doctors are a hard group to work with. We all are independent. We all had different ways of doing it. It's kind of like cooks in the kitchen.
Well, you had your favorite.
We had our favorite ways of doing it. We thought our way was the best, and we did not like medical records coming in and telling us what to do and how to do it. But we did because we knew we had to survive. And we knew our hospital had to survive. Now, this was tough on the hospital. The hospital was run by, of course, it was owned by the county, so the supervisors were in charge of it. But they had a hospital board, and the ones I remember when I came on was Mr. Maddox, James Ward Maddox, and Bill Smallwood, Mr. Deaton, Mr. Kirkendall.
Yeah, and I was going down the same line you are. That's the ones I remember.
And these men were businessmen. And medicine it's a unique business. I mean, in business, if you sell a piece of gum, you want to make a profit on it. And in medicine, you may treat 5 or 6 people with pneumonia and you don't get anything. They don't have any money to pay, but you got to see them. So they were real cautious because they didn't want the county to lose the hospital. They got to make it money. But we had to have new equipment. We had to have new monitors. We opened up the ICU, which we had the 4th floor, but it opened up after we came. But all of that was very expensive, and I have to say that when the board was extremely important in going along with that. Of course, they were like the doctors changing with the DRGs. We had to really talk to them and explain and justify what we wanted.
Well, they were businessmen. Like
they were businessmen.
And they had to look at it a different way.
Right, because something they may buy a $500,000 machine and they didn't see it paying for itself.
Right.
Because then you didn't charge when you put it on there. But it was good for the patient care. We had a low fetal mortality in the county. I mean, we were, when they do the studies, we were always high.
We were always.
And most of that was because we tried to take good care of people. We also had the equipment and the personnel. The other thing we have to talk about is the nursing care. Oh goodness, the nursing care in New Albany has always been superb. When I got here, they did more to teach me medicine than I learned in med school and in internship. And that just continued. We just always had great nursing care. They cared about their people and their patients, and they knew what they were doing. So we were very fortunate. That was our biggest help.
Well, I think that was one of our strengths of our hospital.
Yes.
Our nursing staff was always very involved. They was very involved, and so was the other departments of the hospital. We had a strong radiology director. We had a strong lab director, and pharmacy and dietary. All those areas, we knew we had to work together if we were going to survive. So we didn't leave anybody out. When we started looking at protocols with our physicians, we brought in all the different elements, because not only did they limit the medications our physicians could treat with, the length of stay the physician had to treat a patient with the DRGs, they also limited the number of x-rays, the number of lab studies, the number of respiratory therapy treatments. So we had to do a lot of drilling down to find out what was best practice and make sure what we could offer our physicians, our patients, our community was the best practice. And that took a lot of hard work. It took a lot of time. During that time, they changed our name from medical records to health information management. And they began to add other components, like you had to have a quality program. You had to have a utilization review department. I was very blessed to start those departments during my time. We also...
I'd call that a blessing. We really gave you a hard time about all of those.
Y'all run me ragged, but it was a blessing because he you know, in that article you said sometime my face turned red and you knew you need to quit talking at that time. But there was a lot of hard conversations. It was their patients. They wanted what was best for them. We wanted what was best for our community, our patients, but we also had that cost element. You know, if we didn't get reimbursement, we couldn't get the latest equipment. And of course, technology, I'm jumping around, but technology was moving so fast.
So fast.
We had a portable CAT scan that came. We had a portable MRI. Well, eventually we got to add those in-house, which is wonderful because turnaround time. Y'all needed those. They needed those reports so they could get the patient out in that length of stay. It was a whole new concept in medicine when.
And not just one. I mean, it was changing. The medicines would change and get better. So we treat pneumonia. Used to always on inpatient, and then we got a new antibiotics, and we could go to give them to them, treat it, send them home, which was really scary. Well, you know, the first time somebody came in with pneumonia, and I said, "Well, I'm going to give you these pills, and you go home." And
yes. And the length of stay of pneumonia went from 6 days to 3 days if you were in the hospital. And also during that same time, they began to shift procedures from inpatient to outpatient.
Exactly.
Remember, you know, gallbladder became an outpatient procedure. Dr. Bramlett and Dr. Bullwinkle, we had a good time with those because, you know, all of a sudden you got these lay people like me
telling us what to do.
Telling them what to do. And yes, sir, you can do that gallbladder, but you've got to do it outpatient, unless there's complications.
We did have great surgeons. Now, Dr. Bramlett, he was the kind of surgeon you want to operate in, and Dr. Bullwinkle was too, but Dr. Bramlett he wanted it his way. You had to wash the skin a certain way, you have to put the Band-Aids on, and he wanted his patients to stay in the hospital, you know, several days. I mean, he was hard to turn around. I mean, and he had good points always. But he had Dr. Bullwinkle, when the laparoscopic surgery came out, they went to Nashville and they became the best around.
Experts,
I mean,
really.
they were super, it was great to have a surgeon, two surgeons that, I mean, if you were there, if somebody came in with a acute belly or trauma that you had to have surgery on, they were there and they were available, and that was that made my practice wonderful. Just to have them there. Always, if you called them, they would be there. Same thing happened X-ray, radiologist. Having radiologists, they could come and look at the study and tell us, you know, immediately what they thought. And pathology could tell us what we were looking at when we were operating on somebody, if they had cancer or not.
That was really one of the strengths when Baptist came in.
That was one of the strengths.
They knew in order for our physicians to be able to treat this within this amount of time, 2 days, 3 days, they had to have their reports. They had to have the resources available to them. They had to have radiologists that was willing to read, and we saw that evolve to contract services, in that we had radiologists in the daytime there, but they contracted with radiologists during the night hours. So if Dr. Creekmore had a patient come to ER and he had to make a decision whether or not to admit them, transfer them, whatever, that radiologist at a remote site was reading that MRI or reading that chest x-ray or whatever was going on, and could call and say, Dr. Creekmore, this patient's it needs to be transferred. And so that patient wasn't placed in the hospital and waited 2 or 3 days till a daytime physician could say,
They could go in and be treated. About this time too, our hospital had done well. It had made money, but as you can imagine, reimbursement was getting very sketchy. I mean, the government was cutting down on everything. It was making it hard on our practice. They also began at this time, the industries were feeling the squeeze of our healthcare, the cutting the cost it was. And we were, we had Futorian, we had Beechcraft, we had Ashley, and so they began to form, they were doing their own. They'd have a Blue Cross, but Blue Cross would just manage them. They were funding their own insurance policies. So they could make the rules of what they would pay for and what they wouldn't. And they would come to the doctors and say, we'll let you see our patients, but you're gonna have to agree to these things. You follow these guidelines for when they go in the hospital. If they pay this to your office when you get seen, they wanted us to form a contract with them.
About around what year would this be?
Oh gosh, the 80s.
In the 80s, mid 80s or early 90s.
Yeah, because that was about when PPOs came in.
That's the same time.
Payment organizations, in that they began to drive their business, just like our industries would contract with different hospitals. And it really became a business on that side.
It was us initially, and then the hospital.
Yeah.
So if we didn't agree to sign the contract, well, then we'd lose all of our Beechcraft patients. They would have to go to another doctor, and then it got to be where the hospitals. They were doing business with the hospitals, and so if Baptist didn't get the contract, they wouldn't come see us, because if they had to go to the hospital, they'd have to go to Tupelo or Memphis. So it got to be really uncomfortable. And that's when the Board of Supervisors began looking towards selling and becoming, or leasing to the Baptist or to Tupelo. Those two hospitals were involved.
Those two systems.
And so the medical staff, they let us have a lot of say in that, which was good and bad, because we were kind of divided a little bit. Really, Tupelo's close. We knew all the doctors. That's where our referral sources were. But the big scare was, well, they would come in and we would be a Band-Aid. We wouldn't have a hospital anymore. And our surgeons would dry up, and we wouldn't need the OBs anymore. It was, and Baptist, they thought it would be better. And I think it was a good move, but that even divided the industries up even more, because they really then began to go after, Tupelo went after our industries and Baptist went after them, and we won some and lost some, but how did that ever get worked out? We're not into that so much now, are we?
No, now everybody has a pay rate. They're going to offer you, so we don't have that.
But that was a tough time in medicine. Tough time for us, tough time for the hospitals.
Will you talk about the Band-Aid, the first aid station? What was the fear that what do you mean by that?
Well, if they leased our hospital and we wanted a new MRI, they'd say, no, you just send anybody who needs an MRI to Tupelo. If they say, well, we need a urologist, well, no, you just send everybody to Tupelo. We were afraid that they would not let us continue to grow like we were. Pontotoc had not grown. Ripley had not grown. It's just when you have some hospitals that didn't grow. Now, the truth of the matter is they didn't grow because there wasn't a need for what we had in New Albany. I think if they had, they would have been able to do okay because as we see other hospitals like West Point that people took over, they've done well and they've made them grow. But at that time we were concerned. We had young people working and starting their practices and we didn't want to be left out.
Do you think some of that is because the proximity?
Correct.
I mean, West Point's a lot further to be a Band-Aid.
I don't think so. No, I think it's
No.
because the community needed what they've got. I think it behooves a hospital, I think it would behoove Baptist for their satellite hospitals to have everything that they could support. You know, if we could support a urologist, they would want us to have one because it would make this hospital better, make their referrals better, because they would get then cases that would be complicated that we wouldn't want to do. You know, our urologist probably wouldn't do a radical nephrectomy on someone with a metastatic cancer. So they would get the cases they really are equipped to handle.
Working with Baptist, they were very impressed with the support of our community. They hadn't seen that other places, and the support of our communities to support our hospital and our physicians and keep people here. And of course our marketing people, they had always tried to recruit our local kids back. Dr. Brad Scott and Dr. Shane Scott are examples of that. Dr. Harding married a local girl.
Well, he was kin to the Harrisons.
Yeah, and then Dr. Bullock, that's with Dr. Brad now, he's a local. He came back, and that was a strength. And then also as they talked to them, Baptist is very thorough. They went and talked to our community leaders. They met with them. They brought Clay Rexstraw in when we made our transition to work with us, so we were comfortable with the transition. People didn't lose their job. They were interested in quality, and that helped us as managers making that transition from one leadership style to another. They wanted us, as they saw the support of the community and our physicians, and they really, for a little while it took them, they didn't understand that the Tupelo physicians really respected our doctors.
Yeah, we had a good relationship.
They had an excellent relationship. They took our transfers. They continued to take our transfers if it was the patient's preference, or with the PPOs that we had through our local industries. If they had done an agreement that we could treat them, but if they had to be to a higher level, then they had to go to Tupelo. And we had to work with those agreements. That's just the way it was through those 80s and 90s. You had lots and lots of PPOs. You don't see them as much today as you did then. But of course, we don't have the local industry we had back then either. So people are choosing. Of course, there are Medicare programs now too, though. There are Advantage programs that there's steerage there for care.
The Baptist and never did make us steer our patients one way or the other. So they said they would not, and they have not. We always were free to. It's the PPOs that the industries that made us steer. We had a good referral source in Tupelo. We had a good referral source in Memphis also. But we didn't patient
really
dump. I mean, we didn't.
Yeah.
If we didn't, somebody come in at 10 o'clock at night, we didn't send them to Tupelo or Memphis just because our doctors didn't want to get up and come see about them. We took care of our patients. We liked them, and we were good to them. They were good to us.
And that was such a strength. Baptist was impressed with that. They had not seen that in some of the other hospitals that they had started to manage.
So we were blessed. We had a great staff, great medical staff, great leadership from our medical records, which was very important, as you can see during this period of time. We were audited all the time.
All the time.
All the time.
All the time. Yes.
I wrote a letter one time. Barbara told me, said, "Don't write that letter," because they'd sent back. They'd review our charts, and they sent back on everybody just little bitty things like, "You didn't give this patient the aspirin when you're supposed to, or you didn't do." And so I sent back a letter telling them that, I don't know what I told them, but the next day,
Well, we were doing
we got audited every day.
Yeah, we were put on probation and they reviewed every Medicare chart. It was a hard year, so
Oh my goodness.
we didn't write any more letters.
I hadn't written a letter yet.
So that was a learning experience for both of us, yes.
You already knew, you told me,
But there was checks and balances, so many checks, and which is probably is a very good thing at the end of the day, but it was a hard time. It was a...
But we've come out of it and we do well. Now the changes in medicine
Yes,
kind of mirrored these changes in the hospital system.
yeah.
You asked about, we talked about maybe the practice, the scope of our medicine. When I was in med school, I saw one case of diphtheria, and she was a young girl that was from a missionary. She'd come from, I think, South America. And I didn't ever want to see another one. I had to do a trach on her. She died, the white plaques. It was just like in the textbook. So, people began to get the vaccinations, and we didn't have that here. When I came to New York, we saw a lot of chickenpox in young people. And I had one case that had an encephalitis from the chickenpox and was covered with the sores, left her with scars, nearly died, 103, 104 fever. We don't see chickenpox anymore. I mean, that mumps, we would say the mumps, and most of them did well, but we had a couple of adults that had the encephalitis from the mumps, so we're not seeing the mumps anymore. Measles, used to see the measles, it would be spread, and unfortunately I never did see anybody that was just got really sick from the measles, but I'm glad not to see the measles anymore with the vaccinations. Of course, tetanus I've never seen, and hope I don't. So medicine changed a lot that way. Antibiotics we've already touched on. They allowed us to treat bad illnesses quickly at home with outpatient and with less expense. When we first started, people, Dr. Ellis and Dr. Bostwick would do they would go to home visits. They were real good about that. Dr. Pennebaker was excellent about it. He would make his rounds kind of at home like I did in the hospital. Richard and I started out, Dr. Russell and I started out doing that some, but we were used to getting a CBC, a blood count. We felt more comfortable with it in being able to do the lab we wanted to do. So I didn't do it much. I had a few patients that were elderly that couldn't get out, and so I would go see them. When I was growing up, our doctor, I had one that lived close to me, and he would come see us at times, but most of the time we went in to see them too. Did y'all they come see you at home?
Dr. Mooney.
Dr. Mooney, yeah.
I was remember
We
that.
forgot about Dr. Mooney.
Yes.
Dr. Mooney was at Blue Mountain, and she was in her 90s, I guess, when I was here, and she had a wreck. Going to see a patient one time at night. It was raining. So I brought her into the emergency room, and I said, "My goodness, I've got to meet her." But she did home visits. She was a great lady, very smart. But then as medicine began to we can do more. We can do more tests. We did it in the office because I could draw the blood and get everything back and know what was going on. But still, we have our patient population's getting older and they can't get about. So home health came about, which has been a great thing. Then the end of life, if you came in and we put you in the hospital, and we still do this, but we didn't ever stop. We would just go on, and that was very expensive. Probably $300,000 or $400,000 in the last few weeks. And we learned that there's some things that we can't cure. I mean, we knew that, but people began to understand, and we could do enough studies to know what their prognosis was going to be, and we could talk to them about it. And they said, "Look, Doc, I just want to be comfortable." We could let them go home and have hospice, which would come by, and they could could be at home. And I think that's been a good change in medicine.
And we learned also, that was another area of our case management, we did transitional care.
Right.
Because Medicare would not allow you to be in the hospital if you had no acute symptoms.
Somebody
And we had to learn to measure that, and apply that, but still take care of our patients and still let our physicians come and comfort those patients and family and train. So we developed a transitional care, and so many beds that, at one time, Dr. Thornton helped us open the 5th floor of the hospital as a transitional care unit.
Right.
Because Medicare would reimburse you if you had I'm ready to go home, but I still need a little physical therapy. I still need a little help. Or the arrangements need to be made to help me where I could die at home if that was my wishes. So we had a transitional care, and it was very successful for the time that we had it. And as that reimbursement did away with, but then we start with our case managers and our social workers able to do transitional care, and they were an important tool working with our physicians. We started meeting daily.
Our patients would be cared for,
and you would still meet the needs of that patient and that family. So a lot of changes in the way we had to do things in the hospital also.
They do rehab now.
They do rehab now.
Yeah.
Mm-hmm.
So if somebody comes in with pneumonia,
Yep.
they get through with or they don't even get through with their antibiotics. To get out of the critical stage, they go to a rehab, and they can stay there for a week or two, whatever it takes to get over the pneumonia, finish the medicines, and get up and get therapy and walk around.
Well,
so
that was and it was a learning curve
Right.
with best practices. We found out that younger people that had pneumonia got better with the
getting up and
rehab.
about, right.
They could go back to work, go home. So that was a learning curve, and that's
Same
where we
thing
set
with
up
back
protocols.
surgery, yeah.
Back surgery, yes.
Get them up. We used
a lot
to
of
lay there
changes.
for a week or two.
Yes.
The next guy says, you get up and move around, and they got. So medicine we've learned a lot, and it's really a great thing.
And we adapted. We had to adapt to meeting those needs as
Which
things
was very
changes.
important. Very important.
Sometimes there was battles, learning curves for all of us.
We didn't want to adapt to everything you taught us to
Well, I know, but you did eventually. As long as I nagged, they would come down. No, I mean, it was, I understood starting out with them, which I really kind of did.
Yeah, you did.
I started, and so I understood their frustration sometimes, because we were frustrated too as a hospital. And we wanted both our doctors, and we wanted to be able to take care of our patients and offer our community so we could keep people in New Albany. So huge discussions, a lot of research. That was where Baptist was a strength for it, because they would let us go. Now, I'm very proud to say our hospital set the standard for a lot of our hospitals in the ER, the stroke protocol, that you could get a stroke transferred within 60 minutes. They might have a chance of recovery. Acute myocardial infarction, we set the standard for that, and it was good. We got our Joint Commission scores were some of the highest in the 15 hospitals in the Baptist system, as well as across the United States. And then we began with the quality awards.
Baptist always liked Union City Hospital.
Yeah.
But we always beat them. I don't know why they liked it.
That was their first hospital.
Well, we did.
Plus their president came from Union City.
I didn't know why, but I knew that.
That was our standard.
But yes, we beat them. We were the number one.
But we kind of did that ourselves,
right?
Because we just always wanted to be the best. We wanted to offer the best. We wanted to be there, like I said, for our patients, our communities, our employees. And it wasn't just like our nursing staff or our physicians, it was all of our staff. I coordinated our Joint Commission certifications, and that was a lot of work. There's a lot of standards that you had to meet in every department. And those department heads and managers, they fell right in there. So that was really a strength for our hospital, and that everybody wanted that star,
Mhm.
you know, and was expected. We were expected to perform. And like I said, I just kind of grew up with it. And I guess that's why they
Barbara
really
started out
supported
with
me.
us, and we started out with, what was our first administrator's name?
Mr. Harrington was
Mr.
our very
Harrington.
first, Mr. Fulgel.
Mr.
But
Fulgel.
Mr. Harrington was there when.
Mr. Harrington was there when I got there. He was our first one. We went through a lot of administrators, and through Baptist we went through a lot because we were a training ground for Baptist. They'd send them here, get better, and then they'd go somewhere, and then they'd send somebody else. And so Barbara was instrumental in being that continuity through all of those. They all liked her. They all wanted her on board, and we liked her, and we wanted her on board. So that helped a lot with our hospital.
Well,
And I think the future of our hospital looks really great.
I do.
They hadn't even missed us a bit.
How long were each of you there? How
I
many
was there
years?
50 years, a little bit
50.
over 50 years.
Me too. I started in 72 and you started about then too. You were a ward clerk, right?
I started the hospital opened March of 1966, and I started in November 1966. I filled out my application. They let me start in September, and then I had my birthday, so I filled out my application. And but like
That's
I
when
said,
you were the 16-year-old.
that's when I was still in
Yeah.
high school. I worked weekends, and the ward secretary was a key component because the doctors had paper charts. We didn't talk about that. They had paper charts, and what the ward clerk did was they charted medicines. They took phone calls. They had the charts ready when the doctor made rounds, and Dr. Creekmore, his stack of charts was like this. We had them ready.
Love the ward clerks, you know,
Yeah.
and you know doctors always have great handwriting.
Yeah.
So the ward clerks were good at deciphering that. And they did not make mistakes. It was amazing how great they really were. Of course, they had the nurses watching over them pretty closely.
We did. Miss Ruby Tyre was our director of nurses when you came, I think.
She was.
And Miss Duncan. And she was a hard taskmaster, but so fair. I learned so much from her.
But
She
when
was
the
my
doctor would
mentor.
walk up, they put everything on our side. They had us there. We were kind of petted, and then the nurse would be standing there, and she'd go with us and see every patient. She knew everything about them. It was like me giving rounds when I was in med school, where I would have to tell the attendant what was wrong. So they'd tell me what was wrong, what I needed to do for them, and so that was a fun time for medicine. And of course, by the time I left, I'd go on. They wouldn't even know I was there. But they always would go around with us, but it was different.
Yeah, pretty much make rounds. But then we moved to the electronic record,
Yeah.
and that was something else. I was on the team of the Baptist to go. We had
No,
to
the electronic
pay
records, with
Yeah.
medicine, you got to document. So they had electronic records, put everything down. So you come into the doctor's office, you fill out all this form. You get to know who you are, who your parents are, where you went, what you're allergic. And so every time you go into the hospital, they do all of that plus more.
Yeah.
And plus more. So by the time I'm looking through to see what's going on, I looked at that one little paragraph where the doctor says, they came in today because they had a sore throat and a fever of 101. But the medical records are great because you do know all this information. They're going to get better with time. Information, we've got an information overload.
Yes.
We got more than we know what to do with because we don't know what we need. But as we progress, we're learning what we need, and that's going to streamline things down.
And how much to share across the system.
It's all across the system, So it is good. Medicine's nurse practitioners are a big part of medicine now. They're a good part. The nurse practitioners I know and that I supervise, I trust them implicitly. They have the board of nurses has been good about putting their scope of practice in line, and if they stay in that, then they're getting the guidelines like we had with DRGs. They know somebody comes in with abdominal pain and they got a fever of 100 and they're tender, and you can't say it's a kidney infection or a stomach virus. They send them to the hospital. they have guidelines and they follow them. So I think it works out really well.
And they helped out in the emergency room too. They
They
were
helped-
allowed to
mhm.
be there, and that because most of the time we only had one emergency room physician, but when they allowed us to have two nurse practitioners, they could take the less severe
But the
cases.
triage them down.
Triage them,
Mhm.
right. And while the ER doctor could be working with that severe case that needed their attention, so the turnaround time became better. The care became better because they could get those triaged and taken care of while the doctor handled that case and either get them transferred or admitted. So that was a big change.
There's another big thing in medicine too is the ER doctors. When I first came, there was no
Yeah.
ER doctor. So anybody that came in the emergency room, we couldn't send them home. We had to treat them. So Richard and I were coming in
Yep.
most of the time. As time went on, it got so busy, they began to hire people. They hired a service where people would hire interns and residents to come in and work the emergency rooms at night and on the weekends. Great.
Hospitalist program. We need to
And
compliment
right,
about
and
the
then-
hospitalist
And that
program.
has progressed then to where you have a hospitalist, where someone's in the hospital at all times taking care of the patient. So if my patient came in, and this is when I quit really admitting people to the hospital, my patient came in with pneumonia. The hospitalist, they'd be sick, and I'd send them to the emergency room. I'd have to go up there and stay till they got stabilized, and I'd leave my office so I could send them over and let the hospitalist admit them, and I could take care of them and send them back when they got well, which has made medicine a lot better. And people have accepted because they get better care than somebody's having to try to do it all at once by themselves. Now they've got it for obstetrics. They've got
They
it.
do. I checked. We have a medicine hospitalist. We started that program,
Now they
and
got
then
interns.
now they have an obstetrics.
Which
And-
works out really well. And they'll deliver somebody else's patients if
They
they
will.
need to. So that works out well. The patient accept that because there's somebody there that they don't have to be frightened or be worried. Telemedicine, great invention. It's not for everything, but if you're coming in with a possible stroke, not a neurologist everywhere, the telemedicine, they can look at the patient, they can ask the questions, they can have you do the test in the emergency room, and then they say you need to send, and look at the films that you order, and they say you need to send them on or give them they can help with that mental illness. Somebody comes in and you can't control them. The psychiatrist can look at them and interview them and they work. If you came in with a bullet wound and we did an x-ray on you and we wondered whether it was in the colon or whether it was missed at all, they could do the x-ray. The radiologist can be at home, pull it up on his computer and look and see, and he'll call and say, hey Sam, you need to send him on to the surgeon that's sitting right in this. That's wonderful. I mean, and they don't have to come in and do it. They can do it from home. So technology is making a huge difference. Now, a lot of it, call up and get a pill for weight loss or something. I don't think that's good telemedicine, but so that's going to have to all get worked out, but that'll come like the DRGs. It's just something that has to progress. Health insurance and reimbursement is very scary.
Yes.
I don't think that in America we're going to let somebody come to our hospital and die on the doorsteps without treating them. I think whoever's sick, we're going to take care of. Now, if they don't have insurance, it's going to cost everybody money. This is going to have to be worked out with somebody that's a lot smarter than Barbara and I. But they're going to have to do something about that, I think. Now, in my practice, when I first came, people would be sick. They come in with their children and have a fever. They wouldn't have any insurance, and I never would push them about that. But as time went on, if they came into my office, I had to have medical records. It would cost me $30 to put a new patient into my system. I mean, my cost it would be. have to have somebody there to put them in and look at it, and do the paperwork and all. So it was very hard to take care of people that didn't have money. I had to be more selective at that time, and that was tough. But there are practices. There's clinics in New Albany now that the government that see these people, and Medicaid reimbursed. They get their money. They get paid. They don't do it for nothing. But I would have to do it, so I would send them there, and that helped. Yes, there were maybe one or two midwives, and I think they were probably from Memphis or somewhere that would come in and deliver people at home. But they were cautious. They had to be no risk factors. Their blood pressure had to stay normal, so they had their tight protocols, but they wasn't very often.
So that was
going
just
away.
about over by the time.
And then it started coming back before I left. People wanted to start being born at home, which I personally don't think is a good idea. I think that you never know when something's going to happen, and I don't care what kind of risk factors you have or don't have, but I can understand why people would like that. But I really think, and the way we're doing it now is that it's like being at home. You go into a room, it stays there, your families can come, they're there when the delivery is happening, but you've got a pediatrician there, or primary care, or you got your surgeon, OR team ready, everything is so I think that more people are satisfied being in the hospital and having babies now.
When did you start your clinic?
July of 1972. July the 4th, I think I'd opened up.
Okay. I knew it was 72.
So your clinic started when you came?
I came.
Okay.
The board of supervisors built that building. It was a little blue building, metal building, where the emergency room is now.
Yeah.
And Dr. Russell and I started practicing there. We rented it from him. The hospital has a recruiter, and she does a great job. Her name is Nancy.
Nancy Kidd.
Nancy Kidd. And she's done a great job. She works with us, like we would say, Nancy, we know this young man, and he's in med school, and think he'd be a good asset to, she's on him. Like a flea on a dog.
And the hospital has programs that
Well,
Nancy initiated too, where they go and let juniors and seniors come in and tour in the hospital. And
Which has been a
Dr.
great
Jason
program.
Dees is an example of that. Several of them are examples. That's where they got their interest. It's also where we got radiology techs but the students literally get to spend time in each department. The schools have been excellent. Dr. Creekmore's wife, Barbara, and Dr. Shirley's wife, Ann, were very instrumental in getting those programs started. Cindy Beard worked with them, remember, and they just went out. And so and from then, once they express an interest, Nancy follows them, the junior and senior, through their college. And that's a long time, because,
It takes a long time to get through the residency.
But she stays in contact with them. She goes to the recruitment fairs at Jackson. And Baptists encourage that.
And we've been very successful. But it's a good community. It's got a good hospital. It's got a good staff. Our staff gets along. It's I don't know of any medical staff that has been as congenial as ours has been.
No, that was another plus when Baptists came in.
We were able to get along in spite of our aggravations and our differences. We would come together as a group.
For the best.
For the better, for our patients and for our hospital. So we got, and a lot of young people in New Albany are in med school now.
Yes. And I had that thought. I thought too, one of the strengths of New Albany that we found out over time, I helped Nancy with some of her recruitment back in the earlier days and then on, but one of the strengths with the doctors that came here was that Tupelo's down the road. Memphis is just now like 45 minutes away because of the highway. Our schools drew people here. tremendously, and then the safety of New Albany, the small town community, but they could still reach out to big town shopping and
that's right.
theaters, and that was always mentioned by any physicians that came, like Dr. Medius, other was, when Dr. Bullwinkle moved here, when several of our doctors, they would comment on, this is where they wanted to raise their family. So that was a big plus for us.
That's a plus for anybody that builds an industry here or
Yes.
that wants to start a business. The community that's what brought us here.
Mm-hmm.
What brought us here was when we went to that Bill Smallwood had a gathering at his house, and the young people there that I can name out all of them were our friends my age. They're still here, and their children have come back. My children have come back. That was a great place to live.
That was a huge draw.
And the community, they supported the hospital, they support the school system, they support the sports, whatever New Albany does. They get the park along the river. They all support the museum. The community supports it. It's a great place. I have enjoyed my practice of medicine in New Albany, Union County. My patients have been the best patients that you could ever possibly have. My relationship with the hospital, with the medical staff, the best friends and comrades I could ever want. So it's been a real blessing for me. I think the Lord has taken me and put me where he thought I ought to be. Whether I've done what he wants me to do, I don't know, but I've enjoyed it.
I have. I enjoyed my time at the hospital. It was like growing up. I grew up there, and opportunities came, and God let me be at the right place at the right time. He's blessed me over and over. I worked with some great people. I had a good relationship with our doctors, with our staff, with our surrounding administrators, hospitals. They let me participate in a lot of initiatives that I probably wouldn't have got to participate in elsewhere. And I knew when my time came, there was a lot of good people ready to take our Baptist Union County on. And I was comfortable. It was my time to take care of my family and be at home. But I had no doubts that I was leaving what we had done in better hands. They were going to make it better. So I was blessed many times over.
It was instrumental to the hospital. I mean, if I'd have just been in practice, that'd have been one thing. But for the hospital to grow and to be great, it had to have both. It had to have your side and my side.
And it moved so fast, and and that was.
And it changed all the time.
Changed all it constantly, and you always having to walk this path. The public didn't know about a lot of that behind the scenes. They didn't know about what the reimbursement issues were. They didn't know some of the struggles that our physicians had, still taking care of them, but meeting our needs and getting costs. And you didn't want them to know. You wanted them to come in, get taken care of, and go home. And that was, if we hadn't had the medical staff we had and the leadership we had. And there was bumps. I'm not saying there was bumps on the road.
I never really seen bumps.
You didn't see me crying.
A few potholes, maybe.
So a few potholes, and that was where we were. We keep saying that, we really were blessed, because I knew some of the other records people I worked with and case management people I worked with. They had a lot of struggles. Because you weren't going to succeed if you didn't have that total team concept.
Medical staff stay together, and the administration would give and take, but kind of keep pushing. So it worked out good. The medical staff was closer because of it, I think, because we all had to work together.
One of the doctors, towards the end of my time, I come in my office and there was a flotation device in my chair, and he had left me a note. He said, "Here's for this sinking ship," and I went and found him and
Talked to him.
I did. I said, our ship's not going to sink. Our ship's going to sail on and be so successful.
But in all honesty, there was a worry
It was.
for several years that whether our hospital would survive or not. And the same thing's going on now
Mhm.
with hospitals. We're worried that they're not going to survive. I think we're on solid ground, but
I think so.
I think we had the background. We've got the foundation to be able to stay there. We got off of shaky ground back when we ended up with Baptist.